lab. ICSA Labs currently performs testing and certification of EHR technology to the 2011 standards and criteria supporting meaningful use stage 1, as well as providing custom testing services and testing and certification of other IT security software and products. If you have any questions about our organization or any of our programs, please feel free to email us directly or at ehr@icsalabs.com. With us today, we have our Healthcare Testing Manager, Michelle Knighton, presenting on her analysis of the 2014 edition certification requirements supporting meaningful use stage 2. Today's program will focus on new concepts, changes to the program, and updates to the clinical criteria, including some of the information on the first wave of test procedures that were just published last week. As certification stakeholders, we hope that you find our program helps by keeping you up to date on the Certified EHR Technology program, and this program aids you in your strategic planning. We will be conducting additional webinars focusing in on the privacy and security requirements and the interoperability requirements on future dates, and we hope you can join us for those as well. We've designed this webinar to be interactive, so we'll have some poll questions for the audience throughout the presentation, and we'll also reserve some time for Q&A at the conclusion of today's call. Please feel free to submit any questions you have through the live meeting interface, and just so you know, this presentation will be recorded and made available on icsalabs.com. And with that, I'd like to thank you all in advance for your time today, and we'll move on to the main presentation. And Michelle, the floor is yours. Thank you.
Great. Thanks so much, Amit. We are going to start out with an initial poll question, but before we get to that, just want to let everyone know that you can download the slide deck using the live meeting handout feature. So it should be at the top right hand of your screen. It looks like a few pieces of paper. If you go ahead and click on that, you should be able to download the presentation. And again, before I turn the poll over to Amit to launch, just a reminder to please mute your phone. You should be able to do that either using the mute feature on your phone, or I believe it's *6. So if you could go ahead and do that for us, that would be great.
And so before we get started, this first question is just to gauge the level of interest for folks on the call. So if you wouldn't mind, please describe your interest the best you can in terms of testing and certification. Whether you have no product to test yet, just looking for additional information on certification requirements, whether you have a product to test and you've certified under the 2011 edition criteria and you'll be certifying against the 2014 edition criteria, or if this is something new for you, you'll be certifying and testing for the first time against the 2014 edition criteria, or if your situation is a different one, then please mark other. Thank you.
Great. Thanks so much, Amit. Again, I'm still hearing some information in the background, some speaking. Please either press your mute key or press *6. Thank you. Okay, so it looks like our full results, everyone should be able to see those. The majority of those on the call do have a product that they've tested under the 2011 edition criteria, and they're going to be certifying then against the 2014 edition. So I'm going to go ahead and close that poll, and let's get started.
And I would bet good money that neither Robert Marchuk has ever lost.
Okay, again, I'm hearing someone in the background, and I need you to mute your phone so that everyone on today's call can hear the presentation. So today we are going to go through a few different items. We're going to just do a very, very quick introduction. We're going to then focus on some of the programmatic changes in the new certification program. Then we're really going to focus on the clinical criteria updates and revisions to those, and then just a couple of slides on next steps for testing. Many of you may know that ICSA Labs has been testing and certifying in the security space for over 20 years, really focusing on the testing and evaluation of IT security products, applications, and devices. We also have the distinction of being designated as one of the ONC authorized testing and certification bodies for Stage 1 use testing and certification. And with that came some preparations for Stage 2. So one of the prereqs was to get a couple of additional accreditations. One was by NAVLab as a health IT testing laboratory. The second was accreditation by ANSI as a health IT certification body. So there is a division between testing and certification. That's the reason for both of those accreditations. Additionally, these accreditations were required in order for the ONC to grant authorization for Stage 2 meaningful use certification. So we do have that distinction as well, and we'll be talking a little bit more about that later on. Just a reminder, there are 3 stages for meaningful use, with the option from the federal government of developing additional stages as we move on. The first stage we have been in for a couple of years now, and that was the ability to capture data in a coded format. Now we're currently in Stage 2, which relates to the 2014 edition criteria, and we're going to be able to expand the exchange of clinical information using some very structured structured formats, as well as focusing on the transport of that information. Again, just a reminder for everyone to please mute your phone. Thank you. So we have a couple of just overarching new concepts in the ONC Health IT certification program. So previously we always referred to this program as the permanent certification program because of course Stage 1 related to the temporary certification program. They're doing away with that verbiage. We now need to call it the ONC Health IT certification program. They've also made a revised definition of certified electronic health record technology, and we'll go through the details of that a little bit later. They've also changed the manner in which we refer to the criteria. Instead of just Stage 1 or Stage 2, we're now referencing it as the 2011 edition criteria or the 2014 edition criteria. One thing to keep in mind is that, of course, we have thousands of products that have already been certified under the 2011 edition criteria, and the government got some questions about whether those products that already have logos and marking materials and that sort of thing with the 2011-2012 distinction, whether they would need to update all of those to reflect the new terminology of 2011 edition. And the ONC's answer is no, of course, you don't have to go back and do that. But certainly moving forward with the 2014 edition criteria that's certified, you wouldn't be able to use simply 2013 or 2014 compliant. Instead, it would need to read something like, 2014 edition EHR certification criteria compliant. So that's really the terminology they'd be looking for there. Of course, with this new program, I'm sorry, could you please mute your phone? Thank you. The federal government promised us more flexibility in this new program, and we've got it. So they have introduced new concepts of adaptation, and we have a few more slides later that delves into that a little bit more. But basically, if you have an application that is, let's say it's web-based, and you have modified it to be able to use it on tablets or mobile applications, that certification for the original product will extend to the adaptation. There are some limitations to that, and we'll get to that in just a moment. Of course, minimum standard code sets. So they are allowing for newer versions of adopted code sets to be adopted. So because these criteria span multiple years, of course, code sets are continually updated and new versions are available. In 2011 edition, we weren't allowed to adopt newer versions because they weren't specifically required and approved by the federal government. Well, with the new program, there are a couple of mechanisms to allow for that. So either the Secretary of HHS will identify that new versions are available and will subsequently review and adopt them, or the public could notify the national coordinator about a new version, and they could investigate and then later adopt those. So that's a really good move for 2014 edition. They've also eliminated the certification requirement that every EHR module must be certified to the privacy and security criteria. You'll remember that there were 8 required criteria for 2011 edition. There are also 8 that have been changed somewhat, but there are still 8 required criteria, or 8 security criteria for 2014 edition. So now if you have an EHR module, you're no longer required to test against those security criteria. Instead, those requirements have been moved to the base EHR definition. And finally, gap testing. I know this is something that we're all pretty excited about. If you have a product that was tested in 2011 for the 2011 edition criteria and you're going to bring it forward for 2014 edition certification, you can do gap testing for any 2011 edition criteria that meets the definition of unchanged. So as long as those requirements haven't changed in 2014, you may qualify for gap testing. The next concept is greater transparency. I know that we all sort of had a heads up about these in the NPRM, and quite a few of these have been finalized. So one of the most important things to remember is that a hyperlink to your test results that were used to certify a complete EHR or an EHR module can now be accessed by the public. That will be available on the chapel, and every authorized certification body is required to provide that hyperlink to the ONC for inclusion on the chapel, so that anyone on the public who is reviewing your product information can see the test results that were used to grant your certification. Another really important item is surrounding safety enhanced design and quality management system. Safety enhanced design is kind of just a fancy way of talking about usability testing and requirements for usability. They have designated a template to be used for that. It's the NIST IR 7742. There are specific elements that are required to be documented and submitted related to that template, and that submission of attestation is required if you're also testing against the 8 criteria that has been designated as a need for safety enhanced design. So one other thing to keep in mind is that that attestation becomes part of that test report, which is, again, publicly available. Pricing transparency, this is a really big one. It was a bit contentious, but the ONC felt that it was important enough to providers and hospitals to go ahead and make it a finalized requirement. This does mean that any additional types of costs that a provider or hospital would take to implement the product in order to meet meaningful use objectives and measures would need to be disclosed. However, keep in mind that you're only disclosing the types of additional costs. So whether it's one-time or recurring, just a broad category of the type of costs that they might incur, you're not actually disclosing the dollar amount of those costs. The purchase or upgrade price of an EHR isn't included in that requirement. So this is just additional types of costs that a provider might incur in order to meet meaningful use. Finally, the last overarching large concept are something that we're calling game changers, and they're related to secure messaging, data, and transport. So this is the first time that certification testing has required secure transmission of data as a criterion there for secure messaging. We have an additional requirement to be able to transmit the same information that a patient could download. You have to be able to transmit it using a couple of different exchanges, maybe using direct plus XDN, XDR and Exchange, SOAP stack. And finally, you need to be able to batch export patient summaries, and that's the data portability piece. And this prevents clinicians from being locked into a single system. Next, we just want to further explore that concept of adaptations. So adaptations come from a certified complete EHR or an EHR module. The adaptation, however, doesn't have to have the full capabilities that the certified EHR has, the original product, as long as the capabilities that it does have are full and exact. So what that means here, if we look at our illustration, in the center we have our complete EHR or an EHR module. Now let's just, for example, say that EHR module was certified against 13 criteria. Well, in the bubble surrounding it, we have adaptations that might make up 5 criteria, 12 criteria, 9 criteria. So they don't have to have the capabilities of all of the criteria. However, the criteria that they do have to be full and exact. So that means that if the original product was certified against the record demographics criterion, and let's say that criterion requires the system to be able to record and modify a patient's race, ethnicity, date of birth, preferred language, date of death, preliminary cause of death for inpatient. And now let's say that adaptation says that it contains the ability to record demographics, but it only contains the ability to record race and ethnicity. Well, in that case, it would be non-compliant because that capability is not full and exact. So that's what that means there. A couple of other things to note related to adaptations to EHRs. The reason that they said that the adaptation does not require certification or attestation. So you might have an original product that's certified, you create an adaptation for it. You don't even have to let the authorized certification body know that that adaptation is available, so there's no attestation or certification that's required. And the reason for this is to eliminate the burden and cost related to that. However, keep in mind that this does mean that the adaptation would not be independently listed on the chapel. So that means any eligible provider or hospital, if they're going to generate their 15-digit CMS ID for attestation purposes, they would need to select the originally certified product from which the adaptation was created. So you would need to provide that information to them so that they were well aware of the product name and version number that they needed to use to generate their ID. And certainly, although independent certification isn't required for adaptation, it doesn't mean that isn't an option. So EHR developers can always seek that option, which means, of course, it would be listed independently on the chapel. So there might be some marketing and strategic reasons for why you might want to do that. Any user of the adaptation, so that means the eligible provider or hospital, needs to make sure that no privacy or security vulnerabilities were introduced. So remember that the adaptation is not required to have any of the security and privacy criteria tested or enabled. So one way that might be done to provide those assurances might be contractually. And again, that's up to the implementer of the adaptation. And then, of course, just as a reminder, the providers are always the one responsible for making sure that the product they're using is implemented in such a way that meets any federal or state requirements regarding privacy and security, and that would extend to adaptations. So the burden there is really on the user, but certainly as the developer, it behooves you to make that as easy a process for them as possible. One other thing to keep in mind is that even though the adaptation is not required to undergo certification, and attestation isn't required to be sent to the certification body, the certification body still has control over the certification that was issued to the original product. So that means if they're notified that an adaptation is non-conformant with the criteria that the original product was certified against, they could take action on that, and that could result in revocation of the certification issued to the original product. So that's something that you really want to keep in mind when you're developing those adaptations and making sure that they're compliant. Okay, that brings us to our next poll. So, Amit, I will turn it over to you.
Thanks. And so Michelle just basically went over the concept of adaptation, and so we had a quick poll question around that. And basically, we're wondering if you do have a product that will be certified against the 2014 edition criteria, are you planning to offer an adaptation to customers? And basically, the main takeaway there is that there is additional flexibility for developers of products so that they can port their main product to other devices like tablets or mobile devices. However, as the end user, it's still important to make sure that you take into account privacy and security considerations, and that the certification may not directly test the adaptation. So just something to keep in mind.
Great, thanks, Amy. And it looks like, we'll go ahead and share these results with you. Looks like about 53% think that maybe they'll offer an adaptation, and the others are split half and half. So let's go ahead and get back to our presentation. Next, we just want to go through quickly the revised definition of a certified EHR technology. So one important concept here is that, essentially the first option just under the meaningful use stage 1, so that's fiscal year 2011 through 2013, it just means that it's a complete EHR status. So remember, previously, providers had to possess technology that combined created a complete EHR. So that would be one option for them. However, the second option basically mimics the fiscal year 2014 requirement, which is for MU stage 1 or stage 2, and that's that a complete EHR status isn't required. So the system needs only to meet the base EHR definition, as well as to be certified to the criteria that will help the provider meet their MU statistics. So it's really all about flexibility once again, and making sure that the provider only needs the amount of technology that they require in order to meet meaningful use. This slide, quickly, I'm not going to spend a lot of time here because I'm sure most of you have seen this or something similar to it. It's related to a base EHR. This is the updated slide that shows all of the criteria required to meet the base EHR definition. So there are 20 criteria. One thing to really keep in mind here is that a base EHR is not a certification status. We still only have a complete EHR or an EHR module as a certification status. But a base EHR means that any provider is required in some way to have technology that combined makes up this base EHR definition. And this next slide, I think, illustrates that perhaps a little better. So we have a number of options. The first one is it could be a complete EHR. Inherently, a complete EHR is a base EHR because it would be certified against all of the criteria related to either the ambulatory or inpatient domains. Maybe they have a single EHR module. So even though an EHR module isn't required to test against the security criteria or any of the other criteria that makes up a base EHR, they could. And so a single EHR could essentially meet the base EHR definition. Or perhaps the provider has multiple separately certified EHR modules that combined meets that base EHR definition. So that would be acceptable as well, or any combination thereof. The bottom line here is that the system must simply include the fundamental capabilities that any provider needs to have to demonstrate meaningful use. This next slide was taken from the NEHC final rules presentation that I attended on August 24th. And this is just a quick overview showing you the 2014 edition criteria for fiscal year 2014. So everyone does have access to this slide deck. Again, if you go to the handouts option, you'll be able to download it. So this is just for your reference. One other big concept is related to a common MU data set. It's only applicable to 5 criteria that are listed here. On this slide, we provided the 16 different data elements, and if there's an applicable a standard that's been specified, we've also listed it here. One thing to keep in mind is that for number 15 procedures, you'll notice that SNOMED CT or HCPCS CPT are listed as required, so one or the other. However, ICD-10 TCS and CDT, which is current dental terminology, are optional. However, optional procedure code sets are allowed only if the EHR also certifies to one of the required standards. So let's say you have a dental technology, a dental EHR, and so you want to use CDT for procedures. That's fine, but you also have to use SNOMED or CPT. So that's one thing just to keep in mind here. So this common MU data set just means that all of these data are expressed according to the specified standards whenever they're used or mentioned in those 5 criteria. If you've attended one of our prior presentations, you've seen this slide. This remains for the final rule, so criteria type definitions. We have unchanged criteria. We also have unchanged criteria with or without refinement, but whether or not it has a refinement, it still meets the designation of unchanged. An example there might be the CTOE criterion. Previously in 2011, there was a separate criterion for ambulatory and inpatient, even though the testing was exactly the same for those. For 2014 edition, they've rolled those up into one criterion, so that was an unchanged criterion with refinement. We also have revised criteria. An example here might be patient problems. So PIS previously required SNOMED CT or ICD-9, and now they're only requiring SNOMED CT. So it would not be permitted to use ICD-9. Excuse me. New criteria. This would be brand new, either in one setting or both settings. So an example might be e-prescribing. We saw that in ambulatory, but it's brand new in the inpatient setting, and it's specific to discharges. This next slide, not going to spend a lot of time here again. This is just for your reference. There are 7 different core categories: clinical, care coordination, quality measures, security, engagement, public health, utilization. There are 49 total criteria with 3 optional. So security has 8 criteria with 1 optional, so 9 total, and that's the accounting of disclosures criterion. It was optional in 2011 as well. For public health, there are 6 criteria. Of those, 2 are optional, and those are both related to cancer case, both the gathering of that data and reporting it. And so for that one, that is specific only to the ambulatory domain. But again, it's optional. One thing to keep in mind is that they dropped the patient reminders criterion from stage 1. Instead, they rolled it into this general creating patient list criterion. Just a couple slides now to show you the overall new criteria. There are 13 new criteria, brand new. However, keep in mind that 13 number is a little misleading. We might even call it 12 since e-prescribing is only new in the inpatient domain. It's not new in ambulatory. There are 25 revised criteria. So these existed in 2011 edition and have been revised in some way for 2014 testing. So here, this slide shows us our ambulatory and inpatient criteria. We only have 1 inpatient criterion and 2 ambulatory. So these are revised. And then, of course, we have 11 unchanged criteria, ambulatory and inpatient, and then we have 2 inpatient only. So these criteria would meet the definition of unchanged for the purposes of gap testing. So really important there. And I think this brings us to our last poll question before we delve into the clinical criteria update.
And so for this poll, we're asking for 2014 edition testing. One of the things that Michelle mentioned previously is that EHR modules are no longer required to test against the security criteria. And this is more for just our curiosity's sake. If you do have a product that you're planning to test for the 2014 edition criteria and you're testing as a module, is your plan to also test against the privacy and security criteria even though they're not required? And if you can, please go ahead and submit your response to the poll, whether it's yes, some of them, yes, all of them, no, that's something that you're going to let the base EHR handle, or if you're undecided or if it's not applicable.
Okay, so it looks like the majority are really intending to test at least some of the security criteria, and it looks like we have a number who feel like this would be inapplicable to them. So perhaps they're complete EHR. All right, let's get on with the clinical criteria. So The remainder of the slides related to clinical criteria are all formatted similarly. So first we have on the left the 2011 edition criteria, if that criterion existed previously. On the right we have what it looks like for 2014. You also may be aware that the ONC released the first wave of test procedures on Friday. So if any of these clinical criteria have draft test procedures, we've also indicated whether or not there are any substantive changes in our opinion to that testing. So this first criterion is for CPOE. In 2011, of course, we already talked about this, there was a separate ambulatory and inpatient criteria. Now we see that being combined. There are also just some minor terminology changes. So instead of using the terms modify and retrieve, they're using terms change and access. They really felt like these terms fit better into common vernacular and understanding. And similarly with using the term store, they removed the term store because they really felt like it was captured in the initial requirement to record medication orders. So inherently when you record something, it's storing it was their justification. We do have a draft test procedure on this one. In my opinion, there's no substantive changes proposed. It's still just testing the system's ability to record, change, and access medication orders, lab orders, and radiology or imaging orders. This next criterion does not have a test procedure drafted yet. It's for interaction checking. So in 2011 edition, we saw that this requirement for adjustments to those notifications were required for both drug-to-drug and drug-to-allergy. In 2014, they have limited those adjustments and said that it's only required for drug-to-drug interactions. In 2011, we also saw that there was no specification on the type of adjustments to be made to those notifications, so it was very ambiguous. In our testing, we fielded a lot of questions regarding what types of adjustments to be made. Our recommendation, although certainly not limited, but an example we would always provide is to modify the level of severity of notifications that was shown to the providers. And here we see in the 2014 edition criteria that that is exactly what the federal government intended. So when you're making those adjustments to the notifications for drug-to-drug interactions, you need to make sure it's the level of severity that's being adjusted. They do use the term real-time in 2011. For 2014, they've modified that, and instead they've used the terminology called before the order is completed and acted upon. They feel that that really helps specify that notification should happen during CPOE. For our demographics criterion, previously we used the term gender, and because of some feedback and commentary they received, they really felt that it was more appropriate to use the term sex instead of gender. Also, a preferred language vocab standard wasn't specified, and now it has been, and that standard is the ISO 639-2, further constrained by ISO 639-1. ONB is still the standard for recording race and ethnicity, and in previous testing, the system wasn't required to capture whenever a patient declined to specify their race, ethnicity, or preferred language. However, in 2014 edition, the system specifically must be able to record that declination. For the preferred language standard, one thing to keep in mind is that the EHR isn't required to display all of the languages of the standard. However, it has to be capable of recording a patient's language according to any of the languages in that standard. And I think that we'll see that clarified a little bit more when we see this test procedure drafted. I don't expect too many changes in regards to testing other than making sure you're using the appropriate standard. For vital signs, BMI, and growth charts, in 2011, growth charts were required, and that was a big point of contention for a lot of specialty practices who don't maybe see that population of patients, and this is something that they essentially had to purchase in the EHR that have that capability, even though they would never use it. The federal government heard those comments, and so for 2014 edition, growth charts are optional. They've also removed the age reference, so instead of indicating that the growth charts need to be for 2 to 20 years, they've simply removed that altogether. And then they've made some other modifications regarding terms. Again, we're seeing this use now of change in access instead of modify and retrieve. They've also added an additional verbiage for height, so height or length to better compensate for when newborns are being measured. We do have a test procedure on this. Again, in my opinion, there's really no substantive change proposed in testing. You're still testing the system's ability to record change in access vitals, automatically calculate and display BMI, and spot and display growth charts. But again, growth charts would be optional at this time. For the problem list, again, that same terminology change. One thing to keep in mind is that ICD-9 will no longer be an option for problem lists. You will only be able to use SNOMED CT. However, in the NPRM, it was SNOMED CT only. They've now included the U.S. extension, the March 2012 release of SNOMED with that. So you would be allowed to use that. Instead of using the term longitudinal care for ambulatory and inpatient, they've tried to further specify that. So for ambulatory, they're just saying over multiple encounters, and for inpatient, they're saying duration of an entire hospitalization. So what that means is including situations where a patient moves to a different ward or unit. So perhaps the patient presents at the ED, emergency department, they're then moved to the intensive care unit, then maybe they're moved to just a normal acute care floor, maybe they're sent for radiology. So the entire hospitalization would include all of those movements throughout the patient's stay. And we'll see that definition here, too, for the medication list in terms of longitudinal care and hospitalizations and multiple encounters. The other change here is just modifying some of the terms. So instead of generate, modify, and retrieve, they've again, for common vernacular, changed those to create, change, and access. For this draft test procedure, nothing substantive. Again, still testing the system's ability to record change in access medication lists, and those are both active and historical lists. Medication allergy list, we see the exact same verbiage changes on this one as we did for the medication list. Again, this draft test procedure is continuing to test in the way it's proposed to test in the way that the same manner it has been being tested for 2011. For clinical decision support, one important change here is that they have eliminated the word rule and instead replaced it with intervention, because they really felt that it wasn't just the logic used to initiate a rule that they were looking at. They were looking at any type of intervention. So they feel like this term change better aligns with and, of course, more clearly allows for a variety of decision support mechanisms that are available to help improve our clinical performance as well as our outcomes. So they specifically stated that they recognize that CDS is not simply an alert, a notification, or some type of explicit care suggestion. Instead, they want to make sure we're more broadly interpreting that as any type of user-facing representation of evidence-based clinical guidance. There is no standard specified in 2011 edition. However, we see info button standard being required for 2014. In 2011, there was no requirement for CDS rules to be available to specific users, and now they have limited that to an identified set of users to be able to select those interventions. We do also have a change. Previously, CDS rules had to be based on problems, meds, demographics, and lab test results. They've expanded that list, so CDS interventions now need to be based on problems, medications, medication allergies, demographics, and lab test results and values or results, lab tests and values or results, and vital signs. So keep in mind that whenever you see multiple data elements listed, the federal government has now instituted for 2014 edition and specified that the CDS intervention must be based on at least each one of those, as well as at least one combination. So that means you would need to show an intervention for problems, meds, allergies, demographics, labs, and vitals, as well as some combinations, so maybe problems and demographics or tests and medication. So you will see that definition whenever you see multiple data elements being required for criteria. For 2014 edition, there was no requirement to view some of the information related to an intervention. And in 2014, we do see that, and they specified exactly what needs to be shown to the user. So bibliographic citation, the developer of the intervention, the funding source, and the release and any applicable revision date. So it'll be really interesting for us to see that test procedure when it's been drafted. Unfortunately, it wasn't listed in the first wave of test procedures that were released Friday. I wanted to expand just a little bit more on CDS because they said that there are 3 specific instances when this criterion is implicitly required. So first, it could be triggered based on data that's already recorded and stored. It could be triggered when a patient's information has updated upon receipt of maybe a care summary. It could also be triggered when maybe lab test results are pulled into the system. So there's no specification made regarding the timing of these types of events. So, for example, they don't necessarily specify that an EHR must trigger an intervention at the time of incorporation. Perhaps instead it could occur during the next time that patient's record is accessed or something like that. One thing also just to keep in mind before I move from this slide is that the CDS intervention number 3, that is for the ambulatory domain only, so not required for inpatient. For electronic notes, now this one is brand new for 2014, so instead of the 2011 edition on the left, I've instead shown you the changes from the NCRM to the final rule. So we again see the terminology from modify and retrieve move to change and access. Previously, there wasn't a CMS objective or measure that was tied to electronic notes. In the final rule, they did create that. And so also proposed was the search capability was required both within a note as well as across separate notes. And they got a lot of feedback and commentary on that. And so they decided in the final rule to limit the search capability to only searching within a note instead of also among separate notes. Drug formulary check, we saw this in 2011 edition. We still have the option to either have some sort of formulary list or a drug or a preferred drug list, so both of those are still options. Instead of using the term electronically, they've now added the term automatically and electronically. In 2011 edition, they felt that a hyperlink to a patient's drug formulary that a user had to manually open would potentially be allowable. Now, I can tell you in all the testing I've done, I've never actually seen that particular manner of demonstrating compliance, but since it wasn't technically prohibited, it could have been allowed for 2011 testing. So now in 2014 edition, they have specified that that's not acceptable. The EHR has to perform an automated check for the existence of a drug formulary specific to the patient for which the medication is being subscribed. So we do have a test procedure here. Even though they've made these changes, I don't see anything substantive really proposed in the test procedure. It's still testing the system's ability to automatically and electronically check whether that drug formulary or preferred drug list exists for the patient and medication. Smoking status, we see a number of changes here other than just the terminology changes. Instead of only 6 smoking statuses, we have 8 smoking statuses. So they have added heavy tobacco user and light tobacco user. They've also further defined what a heavy tobacco user is. It would be anyone who smokes more than 10 cigarettes a day or that equivalent quantity of cigar or pipe smoke. and a light tobacco smoker would be a similar description except less than 10 cigarettes a day or equivalent cigar or pipe smoke. For the 2011 edition, the smoking status descriptions were mapped to RECOs, and those were 1, 2, 3, 4, 5, 9. Now for 2011, they have been mapped to specific SNOMED CT codes, and those are listed. You aren't going to have to look for those. You'll know exactly what they are. They're listed in the final rule, and I imagine they've also made it to the test procedure and test data document. Also in 2011, for testing, we were required to ensure the exact terminology of the smoking status was required to display. So if it said former smoker and you had some other concept that meant the same thing but wasn't specifically former smoker, that wouldn't have been sufficient. What is a nice feature is that now in 2014 edition, any words conveying the appropriate concept would be accepted. So just keep in mind, though, that whatever you decide to call something, it needs to match that concept. You also need to make sure you're still mapping it back to that appropriate SNOMED code. And again, for this one, the test procedure, I don't see any substantive changes here. For image results, this is a brand new criterion. So in the NPRM, they use the term immediate electronic access, and when they finalize this criterion, they remove the term immediate. They have also used the term and or, so images and or narrative interpretations, and they got a lot of feedback that said, gosh, you know, that could be interpreted as just or, not and so they have removed the or, and they have specified that this criterion relates to both images and narrative interpretation. They did indicate in the NPRM that they were considering the DICOM standard, but they did not end up adopting it. They did feel that the adoption of DICOM or other standards just seemed unnecessary to enable users to electronically access images and their narrative interpretation. So that's why we don't see any standards specified here. Family health history, this is another brand new one. In the NPRM, as well as in the finalized rule, we see that this is the ability to record, change, and access the health history of first-degree relatives. One thing to keep in mind here is that they have clarified that the EHR doesn't need to be able to access the record of a patient's first-degree relative, but on the patient's record, simply to record their first-degree relative's health history. Structured data is required here. They have mandated either HL7 pedigree standard or SNOMED CT. One thing to keep in mind is that the implementation guide for the pedigree standard is scheduled to be published. However, it's not going to be required for certification, and although it's not required, keep in mind that the federal government has said that they would suggest EHR developers use it as an important guidance document. However, for testing purposes, it would not be required. Patient list creation. So earlier I mentioned that this meets the definition of a revised criterion. Interestingly, in the NPRM, it was only listed as a unchanged criterion, and because they have now combined patient reminders into it, it was moved to a revised status. Previously, static reports were allowed. No longer, dynamic reports are required. So you have to make sure that the end user can create dynamic reports based on all of those required data elements. And we see that list has been expanded. It was previously just problems, meds, demographics, and labs. Now it's problems, meds, med allergies, demographics, labs, and patient communication preferences, although patient communication preferences is only specific to ambulatory. So those going for inpatient certification wouldn't need to demonstrate that one. In 2011, no patient communication preference was defined. However, it has now been defined to include email, secure messaging, mail, phone, text. Now, this isn't a limitation. Your list could be longer than that. You just have to make sure that you're including patient preferences that would be generally available and used in the public. Also a new thing, the lists have to be created using date and time ranges. So that's the new one for 2014 edition. We don't have a test procedure draft on this one yet, and I'll be interested to see it when we do. I don't anticipate too many changes other than some of the specific items listed here regarding date and time, perhaps even checking which patient preferences are available as an option in the system, and certainly that expanded data element list that the list has to be created upon. For patient-specific education resources, we do have a draft test procedure here, and I'll go ahead and start with that. One of the most substantive changes here is that although info button standard is required, there's also a requirement that the EHR has one additional function that can be used to identify patient-specific education resources. So that's really the most substantive change I see here. We do see that the term as well as provide such resources to the patient has been removed. However, the draft test procedure still requires you to show how these resources are provided to the patient, and how you provide it isn't specified, but the final rule does use some examples such as printing, faxing, or emailing, which I think is what most vendors have been using when they have been testing this criteria for 2011. We also have, this is a new criterion specific to the inpatient domain only. It does require the use of synchronized clock standard for the right documentation right. So in the NPRM, the most significant change that we saw is that they specifically said it was right patient, right medication, right dose, right route, and right time. However, they realized that they incorrectly stated right time. What they really meant to convey was right documentation. So they had their concept right, but they didn't have the terminology correct. So it does require the use of assistive technology to verify that those 5 rights are present. Assistive technology, they provided some examples, so certainly you wouldn't be limited to this. It might be barcoding, location tracking, RFID, other things like that. The definition of this type of technology, so assistive technology, would be any solution that when it's paired with an EHR, it automates the comparative aspects of the 5 rights that a user would otherwise have to manually complete. So it doesn't replace a provider's clinical judgment, and it doesn't need to provide even an explicit notification if all 5 rights are correct. However, if one of those rights is incorrect or outside of normal parameters, it would need to give an indication of such to the user. Excuse me. Here we go. For advanced directives, we saw this previously. No significant changes here. This is still only applicable to the inpatient domain. This is an unchanged criterion without refinement, and so I wasn't surprised to see that the draft test procedure is testing this item in exactly the same way it did previously. Just a couple more slides, and then we'll open it up to Q&A. Really quick regarding the sunset of the temporary program, it does coincide with the effective date of the final rule, so the temporary certification program sunsets on October 4th. If you want to do contracts for testing under the 2011 edition criteria using the temporary certification program requirement, that has to be received by your testing lab by October 4th. I'd probably do October 3rd just to be on the safe side. It doesn't preclude you from testing against or creating contracts for 2011 edition testing after October 4th. However, what's important to keep in mind is that beginning on or after October 4th, when the final rule for the permanent certification program is effective, even though you may be testing against 2011 certification criteria, you will still be held to the new program standards. So that includes public test results, price transparency, and things of that nature. So if you don't want to have to comply with those items for 2011 edition criteria testing, make sure you get your contract to your testing lab before October 4th. You then have 6 months from that date to complete testing. Of course, 2014 edition testing is much anticipated. I think we were all saddened just a little bit to hear that would be delayed until the first of the year. And that's because we're waiting on new test procedures to be written and approved by the ONC. And so that brings me to my next slide. So the draft test procedures will be released in waves. And that first wave has already occurred. There will be a 2-week public comment period for each wave. So that means for this first wave of test procedures, comments are due on the 21st. There is a specific email address that you should send comments to. Make sure you put test procedure in the subject line. I have a feeling they're filtering out emails that are coming into that email address, so make sure it does say test procedure in the subject line if you want to make sure it gets read. And finally, just a couple of meaningful use updates just to make sure you're monitoring announcements. We are hosting a number of webinars based on the new criteria. Our next one will be on the 25th, and it's going to cover all of those privacy and security updates. The next one will be the interoperability standards. And then finally, we're going to have one for pilot testing, the new criteria with ICSA Labs. So that brings us to just a quick resource slide. Again, you can access this by downloading the handout. Just the meaningful use, both of the Stage 2 rules, as well as the link to the draft test procedures. So with that, we'll go ahead and open it up to Q&A.
And just to start, we had 2 questions that came in already and a couple that are still coming in. One of the questions we had was around the test results report and that being public. And the question was around what exactly will be part of that test report and what will be the information that's made public. And that actually is in line with some of the questions we've been asking ONC, both in our public comments leading up to the final rule, and what we're hopefully anticipating will be more details to come from ONC and NIST as we have a number of meetings with both those entities as we lead up to the permanent program. But one of the concerns, I think, from the vendor side is making sure that competitive information is not made public, things like screenshots and recordings of how a particular product is implemented or used. But then at the same time, there's a question as to consistency between the various testing bodies and making sure that all of the testing bodies and certification bodies report the results in a standard and consistent fashion. So what we're hoping is that we're going to get the guidance from ONC around a standardized test report template that all of us would use, and that way for people who are looking up their test results, they'll all have consistency between the various testing agencies. Another question was around the test procedures and who is developing them and where can they be found. I believe Michelle did link to the test procedures in the slide deck, and you can download the slide deck by clicking the button marked Handouts on the top bar of the live meeting application. It looks like it's on your right side, top bar. It looks like 3 pieces of paper kind of stacked together. If you click that Handouts, you can download it. Or if you feel like emailing any of us, we can also send that slide deck to you directly. But the test procedures are ONC approved. They will be on the ONC website, not the NIST site going forward. But the test procedures have been written in conjunction with NIST and in collaboration with NIST. I believe NIST has a number of subcontractors that are assisting with them, so it's not a purely NIST-developed product. They have, enlisted the expertise of additional health IT experts to develop these. But as Michelle mentioned, they'll be developed in waves, with the first wave already being published, and we'll see subsequent waves published in the next few weeks. Probably starting with the unchanged or low-hanging fruit, which are some of the items that we reviewed today, and then probably the more complex procedures and those that relate to using test tools. We'll see those coming out later.
Great. And then there was also a question about vital signs, and the question was, if the vendor chooses not to certify against growth charts, is that optional for the vendor or is it optional for the provider? And the answer is it's optional to the vendor. So you can still get certified in that overarching vital signs criterion by only doing vital signs and BMI. Growth charts are optional for certification purposes.
There was also a question on the info button. This is actually going to be covered in a little bit more detail when we do our interoperability and standards webinar. But the info button, if you want to do some background research, it's basically an HL7 approved standard on retrieving information for patient education. So there's implementation guides and a standardized method to retrieve this information, and a quick Google on HL7 info button should get you to a number of resources. And feel free to follow up offline, and I can point you to the specific implementation guides or talk to you about the info button in more detail.
Great, thanks. And then we also have a question about, for ICSA labs, whether we required the MSA, the Master Services Agreement, by October 4th, or the Statement of Services for testing. And Amit, I think that you've been involved in those discussions. Do you know which one we need from for testing?
So the main requirement from ONC is that anyone that is in the pipeline or under contract by October 4th has the 6 months to complete their testing under the same provisions as the temporary program. So for our purposes, if you have an MSA with us, that counts as being under contract. The SOS, or Statement of Work, actually details the exact dollar amount and the criteria we're looking at. But for our purposes and what ONC is defined as in the pipeline, having an MSA with us would be sufficient. There was also a follow-up question on the info button around EHRs that were certified under the temporary program. Now, and whether they need to be recertified. So the temporary program was just the name of the program, not the certification. So any products that were certified under the 2011 edition criteria or the temporary program are still certified as this program transitions to the permanent program. It's more the matter of which edition of criteria you're certified against going forward that's going to be important. So if you're already certified, that doesn't mean you will be uncertified or your product loses its certification as we move to the permanent program. However, you will want to look at the 2014 edition criteria and getting your product retested.
Right, and keep in and another follow-up to that for the info button standard. Depending on which criterion you're looking at, let's say that in 2011 edition for patient education resources, you decided to use the info button in 2011 edition testing. And if your question is, does that preclude you or exempt you from having to do 2014 edition testing, the answer to that would be no, it doesn't exempt you, because remember, you can only do gap testing against criteria that meet the definition of unchanged, and patient-specific education materials meets the definition of a revised criterion. So that's something to keep in mind when you're looking at those criteria. Another question that came through is, if a vendor is still planning to test against the 2011 criteria, are they required to show growth charts? And just like Amit explained earlier, 2011 edition criteria versus 2014 edition criteria, those certifications are separate and distinct. So yes, if you are planning to test against 2011 edition vital signs criteria, you are required to show growth charts in order to get certified for that. You would only be, that would only be an optional item in 2014 edition testing and certification.
We had another question around electronic reporting, and so we're still waiting for the actual test procedures to be published that deal with electronic reporting or interoperability. And as we said before, those are probably the test procedures that will come out a little bit later since they're more complicated. In the past, for stage 1, most of the items that dealt with interoperability or actually reporting or submitting information, those criteria could be satisfied by basically emailing a conformant file, and the interoperability testing was basically more conformance testing, just making sure that the file that you generated was conformant to the specification required. But for stage 2, transport is actually comes into play, and so we would anticipate for any of the items that required submission or secure submission of files that you would make use of the transport requirements. But we'll also be going into more detail on the transport requirements and interoperability requirements in a future webinar. But that is one of the big differences for stage 2 and for certification and testing in general, that this is one of the first times ever that transport is part of the interoperability testing. And so we would anticipate that the criteria that deal with submitting electronic information also include that transport component.
Okay, great. And then we also had a question about the problem list, whether only SNOMED CT codes will be accepted or whether that's still under discussion. It's not under discussion. It's been finalized. We have the final rule out, and they have specified that for the problem list for 2014 edition certification, only SNOMED CT will be allowed for problem list. There is also a question about demographics and whether you can get certified to demographics if you do not do the, I believe they referred to it as the death question. So keep in mind that it depends on the domain under which you want to get certified. So for testing, the preliminary cause of death and the date of death are specific to the inpatient domain, so they're not specific to ambulatory testing.
And there was another question that was looking for more clarity between 2011 testing and 2014 testing. So if you're currently under contract with us, it's for the 2011 testing, and so your MSA and your contracts and your testing engagement all pertain to the 2011 criteria and operating under the temporary certification program rules. As of October 4th, any new engagements will be under what is the permanent certification program, and so we'll have separate contracts and separate materials that relate to that. So basically, if you're under contract with us right now, it is specifically with regards to 2011 testing. As we get closer to the date where we will begin 2014 testing, which will be probably late December or January, in the months preceding, we'll be actually doing a webinar and a call for pilot testing. And so there's some opportunities for folks who are interested to be involved early on and get some additional opportunities to get a sneak preview of the test procedures and help us provide additional feedback back to ONC and the folks that are developing the test procedures as part of that pilot process.
Great. And I just wanted to follow up earlier regarding the demographics question. So I misspoke. The preliminary cause of death is only required for the inpatient setting. For 2014 edition testing, for 2011 edition testing, it's preliminary cause of death and date of death. So for 2014 edition, date of death would no longer be listed as a requirement for the inpatient setting. We also have a question about who can we contact for help determining what requirements must be met for a given product. And certainly if you are under contract with us, that's something that we could assist with, although keep in mind the onus is on you to make sure that your product can meet the criteria. You would want to look through the test procedures and look at the requirements there to help you make that determination. But if something seems ambiguous, we can certainly help you with that.
There's also a question around our recommendation as far as vendors and whether they should be testing for privacy and security. Well, it's a little bit of a loaded question in that at ICSA Labs, our foundation is around security testing. And so I think off the bat, we would recommend to any vendor to examine the privacy and security criteria, to test against them, and give your customers that additional validation that your product does meet the baseline requirements for privacy and security. That being said, the reason ONC introduced this flexibility is that for certain modules, it probably doesn't make sense to test privacy and security. And the topic around exempting particular products for security testing was popular in stage 1 since that avenue did exist. However, there are questions around how consistently that was applied. And typically, if a product dealt with PHI, that was when the privacy and security considerations became more of a question. And for those products that didn't deal with PHI, those were more likely to be able to obtain those privacy and security exemptions. However, it's our stance that, if possible, always look at the privacy and security criteria. These are good functions to have, whether it's a module or whether it's going to be rolled up into a base product. I think one of the things to consider is, even as your module fits into other EHR technologies and combines to build a complete EHR, how well will your base EHR actually cover security requirements that deal with your particular product? So it may not. So I would think each vendor would address privacy and security the way they best could for their module, but we recommend always developing your product with privacy and security considerations in mind.
Great. Thanks for that, Amit. I think that was well said. We have another question. I think this is going to be the final one. The question is, when are you going to start testing, and who should we contact for testing? So remember, we are still doing 2011 edition testing. You can contact us to get those contracts started. For 2014 edition testing, remember, we can't do that testing until the ONC gives the go-ahead, and part of that is making sure that those test procedures have been approved. So they're being drafted in waves. The ONC has said that we should anticipate not testing for 2014 edition until later this year, or potentially the first of the year, so January of 2013. So with that, we are going to go ahead and wrap up. Thank you to everyone who attended the presentation today. If you need the slide deck, please let us know, or if you have any questions, don't hesitate to contact us, and we look forward to hearing from you at future webinars.